Certainly a privilege for me to be here today talking with you in this very exciting time in HCC. We've seen a gigantic landscape change over the past 2 years, and I guess I'd like to start by asking you, how do you perceive the changes in the landscape since you began your career in HCC? Josep?
Certainly, I mean, thank you, Kelly. It has been a revolution these past 2 years. So I remember I've been in the field of HCC for 24 years now. And then I remember at the beginning that the patients with advanced HCC, I mean, unfortunately, we did not have anything for them. Suddenly, the first breakthrough happened in 2007, as you may remember.
I was at that ASCO.
You were at ASCO. And this was a breakthrough, a milestone, I would say, in the management of the disease with the first drug, systemic drug sorafenib. And then after that, we thought that after sorafenib, okay, it will be easy, other drugs will be coming very fast, and it was not the case. So for almost 10 years, nothing. And the past 2 years, we have had this revolution that we have 6 additional drugs. So for me, I think it's a very exciting time. Do you want to talk a bit about the differences in improvements in survival that we have experienced with these drugs?
That's absolutely the goal, is not to just have more treatment options, but also to see people living longer to try to treat them. And I think it's quite remarkable to see in the last several trials from regorafenib with the RESOURCE trial, seeing second-line patients living throughout the course of their systemic therapy now up to 20+ months in the 26, 28-month range, and patients who are able to get multiple lines of systemic therapy, and now exceeding the 1-year benchmark for first-line survival in the REFLEX trial with sorafenib and lenvatinib, both drugs surpassing that, what we thought was an unsurmountable barrier. Now it really is a testament to the efficacy of these new therapies, though I think also in part better ability to provide supportive care and also refine the patients that enter trials. What's your perspective? Do you think the survival times are improving purely as a metric of better trial design, or also the ability of sequential therapies to help?
Yes, well, there are 3 issues. The first one, as you mentioned in the REFLECT trial, there is a matter of selection of patients that have main portal invasion were excluded, and also the management of the disease, and in general the management has improved throughout the last 10 years. But also we have the issue that nowadays, you can recall that after lenvatinib in the trial, a percentage of patients, close to 1/3 of the patients, were receiving sorafenib. So now we have second-line therapies that are effective. I'm not saying that sorafenib is a second line, I'm saying that after lenvatinib, some patients switch to sorafenib. And certainly, I would say that for the next trials to come, we will see more and more survivals around 15, 18, 20 months median survival in frontline, because we have second and eventually third-line therapies in place. So do you want to talk about eventually a bit about predictive biomarkers of response? It's a very complicated issue in HCC. Certainly, for instance, only one drug, ramucirumab, is actually effective in patients with AFP more than 400. That is a good biomarker for selecting the population with aggressive disease. But the classical biomarkers, biological markers used in oncology, HER2 amplification or mutations in KRAS, wild type, so on and so forth, are not effective in HCC at this point. How do you see the field evolving here?
I think that's definitely been the challenge of having HCC reach the genomic age in oncology, in that there haven't been classical driver mutations consistently within tumors or across patients. And that often tumors are much more heterogeneous, and having multiple drivers accumulate over the long evolution of development of cancer. But the a couple years back, we were starting to study MET-targeted therapies in a MET-selected population, and the Tivantinib story with the MET of HCC study did not show a survival benefit for MET overexpressed HCC by immunohistochemistry, at least for that particular genomic target, but or expression-based target. Though, as you alluded to, I think the ramucirumab data that we'll talk about more in a minute is certainly exciting as the first biomarker-selected agent in HCC. But as we now have these multiple drugs available for sequential therapy in the oncology office, it is really hard to choose between drugs and know how to sequence them. And I think what will be incumbent upon the studies ahead and the work we do with the samples is to try to refine what are the markers of response and predict those patients most likely to benefit from one strategy to the next as we have choices at progression for the first time.
Also, the effective drugs in the field of HCC, most of them are multikinase inhibitors. So these kinases, sorafenib, regorafenib, lenvatinib, cabozantinib, that block several kinases at the same time. It's very difficult to find out a biomarker here. You need probably a gene signature or something. But certainly with RAMU, we have the AFP. And now with checkpoint inhibitors, as you are familiar with, there have been some studies trying to identify what is called the immune class, or on the other edge of the spectrum, the immune-excluded class. And there is some already preliminary data also coming from Memorial, and we have an editorial talking about that in clinical cancer research, that patients with beta-catenin mutations look as those that may be primarily resistant to checkpoint inhibitors. This is also only preliminary data, but it's giving us some idea on how we can navigate in the treatment strategy based on biomarkers. Of course, this needs to be validated, but it's the first step.
It also is reminiscent of what we see in melanoma, too, with the beta-catenin and Wnt pathway signature. So I think that work is really provocative and in large part from your lab.